Are you a farmer?
No, I'm not a farmer, are you?
No, I'm not a farmer.
Well, why are we guarding these silos? If we work in silos, we can't share needed patient information. The two organizations can't work together to provide the best care.
Together we can build systems and bridges, not build silos.
Ooh, that's good.
Let's talk to some of our clinical partners to see how they make this work.
Ms. Bartu, I understand that one of the CMS Innovation Grants was awarded to Vanderbilt to work collaboratively with NHC, and that the goal of that grant was to improve transitions between acute care and post-acute care. Many of the post-acute care providers have used Dr. Joseph Auslander's Interact tools, but this is the first grant to pair acute care and post-acute care. I'm interested in learning about the impact tools being used at Vanderbilt, and specifically the nursing transition summary, and how it supports a seamless transition for patients. I understand that you all refer to this form as the NUTS form.
We do. It's a NTS, Nursing Transition Summary. We do call it NUTS for short. And it is kind of nuts and bolts, and it's a summary of what information they should be getting and more. So what we did is we collaborated with the nursing facilities, and we asked them, when you get a patient and that big stack of paper that comes with them, what is not in there that you really would like to have that would really help you to keep that patient healthy right off the bat? And we put it into forms, and we had them review it and go over it until we kind of finally honed it. And we keep continuing to fine-tune it as well, so that it's the information that is sort of the right now information that's going to help them the most. And how is it that you'd like to get that? What form would you like to get it in? And so we came up with the Nursing Transition Summary. And just to show you kind of the bigger points, highlights a section here. It's the 3 to 5 things that we believe may make that patient ill again soon if they're not carefully watched, and even maybe a suggestion for how to monitor those things, and a little bit of a history of those things that are sort of the biggest concerns for that patient as they come over. So what we do is we take this NUTS form and we fax it to the nursing facility, and we go ahead and give what's called a warm handoff phone call. So as the patient is arriving, they've got this information by fax, and then we call and we go through it with the admitting nurse to make sure they understand what the highlights are, where to find some key information that they're going to need to know, and the medication transition or the medication summary as well. And we ask for any questions that they may have, so that we're sure that they have a really good sense of where that patient is at this moment in time. And then those admitting nurses are also responsible for taking this NUTS form and being sure that the nurse practitioners or the primary care physician is aware of what's in it as well.
Very good. Well, thank you for helping me to understand about this important impact tool.
Sure thing.
All right, well, there's one more impact tool I'd like to find out some more about, and that's the medication reconciliation form. Can you tell us why this was developed and how it helps reduce the risk of medication errors?
Absolutely. The Impact Innovations tool was developed with pharmacists to provide one source of truth for the facilities who receive many different lists of the patient's admission medication orders. The goal is to not only provide one list for the facility, but also to document changes that were made between the patient's pre-hospital medications and the patient's current admission orders, and explain the reasons for these changes. A second goal is also to make a prospective plan for these medications, including pertinent monitoring or adverse events that the facility should be aware of. The third purpose is that pharmacists screen the medication orders compared to the patient's hospital course to see if there are any medication errors that need to be resolved.
Thank you very much.
Absolutely.
So, Ms. Heath, as the Director of Nursing, I wanted to ask you a few questions about the use of the Interact tools along with the Impact tools and how that helps with a more seamless transition for patients.
Okay, well, Tim, you know we have integrated Interact throughout the entire healthcare delivery system now. Our CNAs use the Stop and Watch tool. They use that to help report observed findings with the patients to the nurses. The nurses use the acute care change in condition cards and the care pass. We found one particular tool, the SBAR, especially helpful. Now that SBAR stands for Situation, Background, Assessment, and Report. They use that as a formatted document to report their assessment findings to the physician and the nurse practitioners.
Very good. That was very helpful, and thank you.
You're welcome.
Mr. Winton, I understand your Quality Improvement Committee uses outcome data from this project. Can you tell me how that works?
Tim, we agreed to participate in the Vanderbilt CMS Innovations Grant because it's not strictly research. It's also quality improvement. We use the quality improvement to discover where we have opportunities for improvement. And we get that improvement from the data that we input into the computers on a daily basis during the month.
Bethany, can you tell me how the nurses gather this information for use?
We have our nurses input information into our database system every new admission. This helps trend, and this provides information on our readmission rates that we can utilize and review in our QA committee.
Dr. Slanzicki, I understand that when this information is gathered and compiled at the end of the month, how do you use this data to improve outcomes?
As part of the medical team, the Vanderbilt physicians and myself review the information that's presented to us, and we try to take into consideration the social factors, emotional factors, and medical factors, as well as considering needs of the family. We often consider whether or not palliative care would be appropriate for this individual, and we try to retrospectively evaluate the transfers back to the hospital and try to identify whether or not our processes could be improved in a particular way in order to improve outcomes.